Hi, you all. My name is Johanna Allen. I'm a nurse midwife. I work at Viva Eve, which is a women's health OBGYN care facility for women's health and fibroids and prenatal care and postpartum care and birth and deliveries. So tonight we're discussing labor and delivery, birth. Then we'll just go through different stages of labor and coping measures, and hopefully we'll all learn something tonight, or at least go into this process feeling a little bit more informed and ready for this process and event. This is just a little bit of information about me. We'll skip through just to get to the meat of tonight's discussion, but you can also refer like info about myself and my fellow providers of Viva Eve on our website. And same here, like who is Viva Eve? There's a really detailed website that you can refer to. If you're not a patient of ours, of course, welcome to come and join, and hopefully you're getting care at a place that you feel really good about. And it's just about our approach, and hopefully same for all of you, wherever you're receiving care, that you feel like you're being listened to and that your care is tailored to your needs, your questions, your preferences. Let us know how we can support you. Your provider always wants to know that. So yeah, today we'll cover labor and delivery, what to expect, and how to go through this experience, including the pain that can be involved. And I wanted to just address that we consider a full-term pregnancy to be 37 weeks to 42 weeks. There's, of course, all that emphasis on the due date. That's the 40-week mark. Everyone's going to be checking in, like, have you gone to labor? Have you given birth? And, just let people know, like, yes, that's an important marker. We, of course, use that as, like, an important indication that your baby's lungs are well developed. But it's okay to deliver a little bit before or after that. 37 weeks, the reason we consider that full term is that by then baby's lungs are well developed and they can breathe on their own outside of the uterus. We know that we can feel pretty good about that if they're born at least by 37 weeks. And then 42 weeks, we give that as like a marker for the end of full term, because at that point we are concerned if a pregnancy goes beyond that the placenta is maybe not functioning as well. It's a temporary organ. So that's why we look for labor and delivery to take place before then, so we can make sure that baby is getting all the oxygen and nutrients necessary in labor. As you can imagine. So yeah, we'll kind of talk more about this, but if you think about, but with contractions, that muscle is tightening a lot, and then that's just meaning baby is experiencing that tightening, potentially its blood supply. So we just want them to be getting everything that they need during that process. So then the types of deliveries, this will kind of go mostly into spontaneous vaginal delivery or induction of labor, in the sense that we're going to be talking about labor, which with a cesarean delivery, if it's scheduled in advance, someone wouldn't necessarily go into labor, but hopefully there's still relevant information for the delivery process and some of the things to expect in your birth setting, like the hospital for a C-section. Labor. So this process is your birth, your child's birth, and labor can begin in two different ways, with contractions of the uterus or with the rupturing of membranes. It's the amniotic fluid, the bag of water is breaking. And then associated with those things leading to changes in the cervix. So the cervix, of course, is that kind of gateway, that like between the outside world and the uterus where the baby is living. And so we are always looking at a few things in labor. Are the contractions contributing to changes in the cervix? That's what we're looking for, like, okay, this person's in labor. And the cervix will first typically get thinner and softer, and then will start to open. Sometimes if someone's already given birth, their cervix might actually be a little bit dilated. Like we tend to see that usually in people who've given birth before. Maybe their cervix is sitting like a couple centimeters open at the end of their pregnancy. And then, so those contractions and those changes in the cervix then leading to delivery of the baby. That's, the uterus is the strongest muscle in the body at the end of pregnancy. That uterus is ready to transition and push that baby out. So just know that your body is ready for this and very strong. You've really been bodybuilding on multiple levels. Like you're building that baby and your uterus is like getting the work out of its life. And then there might be some changes that we'll go into as well that you might notice contributing to labor. But really we're kind of the main definitions of labor involving changes to the cervix, those regular ongoing contractions of the uterus, and maybe the water breaking. We'll go into more details though. But I wanted to just see how people are feeling. How do you all feel about this upcoming process? Does anyone want to share in the chat? It'd be great if you want to just type in how you're feeling and we can share. Don't be shy. Well, I'll just say, like, in my experience, for some people that involves feeling really terrified. Like, this is something I've never been through before. My body is about to go through this major change. I hear it's really painful. Some people are like, I'm just excited to meet my baby. Some people are like, I'm so uncomfortable at the end of pregnancy that like, I just want something to happen so that this pregnancy is over, because the end of pregnancy is so uncomfortable. Oh wait, do we have some answers?
Yeah, someone is saying that she feels very nervous.
Very nervous. Yeah, that's so normal. Yeah, that's like very understandable. And I'm hoping that like something like tonight and hopefully with conversations with your care provider team, your family, will help you to feel less nervous, but so normal to go into this process feeling that way. And I think it kind of is like getting us ready. Like, it's such an intense process that it's just preparing us for the intense experience of also meeting this new life that you all have been growing, so it's kind of uncomfortable to sit with those feelings sometimes, but also, maybe just kind of welcome them as a part of this huge momentous process and occasion. If there's any other additions, just let us know throughout the chat. Keep sharing.
Perfect. Yeah, of course. So for the first, the next slide, why don't you tell us how you really know that you're in labor? What are the signs? What's my body going to tell me?
Yeah. Okay. Yeah. $1 million question, right? So like I was saying, the contractions are something that was like an external piece that you will feel and be aware of, and that we can kind of like, as your birth team, as your providers, we can monitor. So for labor to happen, and we'll go more into what I'm sure you guys are all familiar with feeling and hearing about Braxton Hicks contractions. But the difference between those kind of pre-labor contractions and the labor contractions is that they do not go away. No matter what you're doing, you're lying down, you're taking a shower, you're eating, you're walking, and they're just like coming on, they continue, they're getting stronger and closer together. So we kind of say that someone we measure that by saying that there's 60 seconds or more that they're lasting, and they're coming every 3 to 5 minutes. And we'll go more into kind of how to time them correctly. And yeah, they're getting stronger and not going away. And so these are all kind of opportunities to check in with your provider. If you're like, kind of make a plan in advance, like, when should I contact you? Because it's kind of different for everyone. Like, if you live next door to the hospital or birth center, like, you might not necessarily need to let them know right away. But if you're like an hour away, you're like, there's traffic, or like, let them know sooner than later if you're kind of getting to this point of like, I'm having contractions that are getting stronger and closer together, even if maybe they're not quite 5 minutes apart, just to check in, make a plan. Okay. And then bloody show, we sometimes see. So that is not necessarily meaning that you're going into labor right away, but the bloody show is a sign that your cervix is getting softer and opening a little bit. that mucus plug that is kind of part of that barrier between the outside world and your baby leaves the body. And we often see that that will mean that someone would go into labor within a couple days. Not a guarantee, but it doesn't mean someone's like definitely going into labor right now, but your body's making some changes to head in that direction. And then the nausea and vomiting, sometimes we can see that like less so at like the beginning of labor, but more in the transition stage, what we call, we'll talk more about this, but towards the end of labor and getting closer to the time of birth, all those changes in hormones, and you can just kind of imagine like just that physical act of contracting, that uterus is taking up so much space and strength. There's just like less room for the digestive system. Everything's getting pushed out. So things are coming up, and vomiting can be a really normal part of labor and delivery. No one really talks about that because it's not the prettiest experience, doesn't feel good, but sometimes you'll note it, like the providers might be kind of like looking at each other like, oh, they're getting close, you know? So it can be like a good sign. Doesn't mean that we're like happy or vomiting, but in some ways we're also just like, oh, this is going places, you know? And then, yeah, the water breaking. So that can take different forms. In the movies, it's like waterfall, right? Like explosion. And that can be the case. Like you might end up with a big puddle underneath you. But it could also just be like more of a small trickle. So important to kind of keep an eye on that. If you're like, my underwear is more wet than usual. What I like to tell people is like put a pad in place. If you're noticing that pad is saturated, like over the course of the next couple hours, like you're like, this is wet again, something's different, check in with your provider. Sometimes people will leak urine at the end of pregnancy, but we just really want to make sure it's not the amniotic fluid, because if it's been ruptured for a while, there is just the risk of infection. So because that amniotic fluid is a barrier, again, between your baby and the world. And so if bacteria is rising up and through the vagina and cervix into the uterus, there's just a risk of your baby getting infected. So it's important to check in. So again, like going back to kind of the full term piece, if you're not full term yet and you're experiencing these things, definitely check in sooner than later with your provider, or like right away with your provider. But if you have kind of made a plan to have like an early labor at home, you could kind of manage that at home and just, but with that kind of knowledge that like, I definitely will contact my provider when my contractions get stronger and closer together. And then anytime we think your water's broken, contact your provider.
Cool.
Yeah.
So that's how we know we're in labor. But what about like Braxton Hicks?
Oh, yes. Yeah. So
when does that start happening? Right. What are they? How do you tell that it's like not real?
Right. I think that's such a good question that most everyone has. So you maybe like some of you have already started feeling these. If you're in your like second and third trimester, the uterus is kind of like warming up, like it will contract and effectively make a contraction. The difference between those contractions and labor contractions is that they're not associated with cervical change. So you might like notice a few and then they go away. But again, like if they're not getting stronger and closer together, probably Braxton Hicks. If someone's like feeling these and they're like, that I've had a few in a row, what's going on? I would try drinking water, because dehydration can contribute to like kind of uterine irritability. Like if we're dehydrated, any of our muscles like might start cramping. So drink some water. There you go, Sierra. Sarah's drinking her water bottle. Keep that water bottle with you at all times. And make sure that, drinking those 2 liters a day to the point when you urinate, it's like straw colored. And then you can kind of know like, okay, I hydrated, they went away. Or, like I'm resting, like take a shower, rest, hydrate, see if they do go away. And like this, some sources will kind of say like, if it's less than 4 an hour, then it's probably just Braxton Hicks. But again, it's that changes and they're getting stronger, closer together. Please contact your provider, no matter what week's gestation you are. Okay.
And they're normal. You don't need to be worried about them.
Very normal. Yes, exactly.
Totally normal.
Very normal. Like almost expect them to happen. Like everyone experiences them. Yeah.
Okay. So why don't we talk now about, you mentioned before, timing your contractions,
Oh,
knowing that they're the real deal.
Right.
You're going into labor.
Right. So
How do you time them?
yes, that's a great question, because I think sometimes, like, you'll walk in to meet someone in labor and they're like, the contractions are not stopping. They're just coming, like they're nonstop. I mean, I get them every minute. And then you kind of have to see like, okay, well, let's figure out what's going on, because there is like a way to communicate the timing of the contractions that is like an accurate way to just like let people know, like, you're at home, this is what we're seeing, and communicating with your provider. Start timing them from the beginning of the contraction to also when it ends. So you kind of know, all right, this is how long that contraction is. But then to kind of time that's like the length of the contraction, to time the frequency of the contraction, start by timing the beginning of the contraction to the beginning of the next one. So like that, and then that way you can kind of know that provides like more accurate information to share with your birth team. And then this 511 rule can be really useful, like especially if you made that plan with your provider to labor at home, say like with partner or family doula. Definitely be heading to the hospital, be in touch with your provider if you're having a contraction every 5 minutes and it's been lasting for a minute, for an hour. That changes if you give birth vaginally like 3 different times, or even twice. You tend to have shorter labors. So definitely, like, this is not a hard and fast rule, but especially if it's your first time laboring, it's good to have some early labor at home, and especially if you have a support team. But know that game plan changes when you're having contractions with meeting that 511 rule.
Cool. All right. So how do we prepare for this?
Yeah.
Because you just mentioned like having your plan to maybe labor a little bit at home.
Right.
Doing those things. How do you prepare to make your kind of plan?
Yeah. So definitely like communicating with your provider and birth team and making a plan. Sometimes that means like, if you feel good, like writing out a birth plan. Sometimes that means just having a conversation. But really just like doing the things that are going to facilitate your body doing what it's made to do. And so it's really just taking care of yourself is the main thing. As much as you can rest and, again, hydrate and eat well. So like really nourishing foods that have like healthy fats, salmon, avocado, and whole fruits, whole vegetables, those things. Getting 7 to 9 hours of sleep at night if you can. And walking too, movement's really important. It helps to really prepare the pelvis for labor and delivery, releases those soft tissues, the ligaments and tendons, so that the baby has space to navigate the pelvis. We often think about like, oh my God, are my hips big enough? Like, is my pelvis wide enough? Your body, like that, all the hormones that are surging through, relaxin, those things are progesterone loosening the joints of your pelvis to prepare that your pelvis to expand. What kind of can hold things up more is having like tight, soft tissues, because it just babies like having trouble turning. They're so participatory in this process. They're like wiggling down and moving through. They're like heads getting crushed. Not crushed, sorry, that was dramatic, but like there's everything's getting squeezed. And then they're like trying to like reach their neck forward through your pelvis, their heads down usually. But so just like making things as easy for them as possible with not having like everything super tight. So walking helps, prenatal yoga, getting a birth ball and kind of like sitting on that, keeping your knees nice and wide and doing kind of like gentle hip rotations. Those things can all help release the soft tissues. Packing your birth bag. I think everyone got a copy?
We'll send it after the event.
After this event. So the marketing team put together this really nice pack list for what you can take to the hospital or to your delivery site with you. And it's super useful. Really, like the main thing, car seat, number one, because you need a way to get your baby home safely. And then also, and like practice putting it together beforehand, because if you're going to be trying to like leave the hospital potentially at like some ungodly hour, late, it's dark, or maybe not. Oftentimes people leave in the morning, but you're tired. You have a new baby, and it can just be so complicated. So practice. Different like fire departments have classes and like instructors to help you do that. So look into that in your neighborhood. So yeah, car seat, and then just like things to make you feel comfortable, whether like a gown that you will wear or a robe, things to make you feel cozy. I would suggest things that like maybe you're okay with parting with because they might get body fluids on them. There's just a lot of body fluids involved in labor, as we've discussed, amniotic fluid, some blood. I get like, we can go into this in a little bit, but sometimes poop in labor. So it's just a lot of things can get on, and not to mention all the things coming out of babies. So things you're not too attached to, but that make you feel comfortable. And then things like photos, electric candles, like stuff to just make you feel nice in your room. Pillows, I think that's also really nice. Just a number of pillows. And then things for your birth support team too, for partners, doulas, whoever, like just to have snacks for everybody involved, and changes of clothes for them too. Okay. And then just like see where, okay, how do we get to this place where we're giving birth, or the hospital birth center, and do like a trial run so you know how to get there, have multiple routes in mind in case there's this crazy New York City traffic, and then like where to park and make a plan for that so you're not just like scrambling. And then because oftentimes people are heading to the hospital or their birth center in the middle of the night, so just make a plan for that. And then and maybe it's like that means like someone dropping you off. That's kind of nice because then you don't have to worry about parking. And maybe if it's someone it's okay if you have like amniotic fluid in their car and it's not an Uber. Just saying.
Does that ever cause an issue in Ubers?
Oh yeah,
And
seen a lot of amniotic fluid in Ubers, and some of them are so nice about it, and some of them are like disgusted, or that's their problem though. If it happens, it happens. You just need to do your thing. But sometimes it's nice if it's a family or friend or something. And then like if your hospital provides or birth facility provides a specific childbirth education class, that's nice because they might be able to kind of address the specifics of their facility, like the layout and kind of what to expect. And because it does differ from place to place. So I can't necessarily speak to all the specifics of everywhere. So I recommend that if it's available. I know like for our patients delivering at Mount Sinai West, they have a virtual class available. So I definitely recommend checking that out.
It's good to know. All right, we can now talk about the different stages of labor.
Okay.
So
awesome.
I know we've talked a little bit about what it is and how to recognize it, but I guess let's talk about the stages of it.
Awesome. Yeah. So because you might hear like your healthcare providers talk using these terms. So like the first stage of labor is really consisting from when labor starts, again, with like regular contractions or the water breaking to the point of starting to push. You're fully dilated and you're ready to push. Okay. So that, like I just spoke with earlier, we see like the cervix softening and thinning typically. And then that could be also characterized with like some contractions, but they're not, it's like pre-labor. They haven't got to that point of coming every 2 to 5 minutes. Okay. And then we do see with early labor, that's when those contractions are more regular, coming every 2 to 5 minutes, and dilation happening. So that's the cervical changes. That's the definition of labor. If you're now in labor because your cervix is opening. And so that's like kind of the stage. It can take a while too for a first time laboring person. It can be hours of being in that early labor phase. And we're not necessarily so concerned about that. We get concerned if you're getting tired or dehydrated, or like if there's any complications with baby's heart rate or anything like that. But if everything's going well and it's just taking a little while, that's okay. Once someone reaches active labor though, we are going to be expecting progression, kind of more predictable progression of, when I say progression, I mean dilation of the cervix. So kind of like more consistently dilating from 5 to complete to 10 centimeters. Someone's completely dilated when they're 10 centimeters dilated. And that's when the baby's head can fit through. Okay. No cervix is felt so in labor, your healthcare providers, whether that's nurse or midwife or OBGYN, whoever's attending to your care, they will probably be doing cervical exams, cervical checks, and checking their dilation using 2 fingers. So like I insert 2 fingers inside the vagina, and then I feel with kind of separating my fingers, you kind of learn with experience, like, okay, this is, I know like 1 finger is kind of a centimeter, a little over, and then like 2 would be more like 3 centimeters. So you learn to measure the dilation, to also measure progression. Okay. And then we're also seeing in active labor, that's when we are seeing contractions more like every 2 to 3 minutes. And then also in terms of like your baby descent, moving down into the pelvis. If a baby's kind of staying up high, we're like, what's going on there? We might have some questions. We're always just, those are things we're monitoring along with your baby's heart rate and everything.
Cool. So continue to tell us about the rest of it.
Okay.
We're almost ready to push.
Yeah. So then transition kind of refers to the end of active labor, where like you're dilated 7 to 8 centimeters until you reach completion. And this looks a little bit different for everyone, but it also often is just like, huge surges of hormones moving through the body. This is when we might see that nausea and vomiting. And baby hopefully descending into a good place to then begin pushing. So then that's second stage of labor is full dilation, and some people define it as like full dilation, 10 centimeters, or like, or an urge to push. But sometimes people have that urge even earlier because baby's moving down. So like, if you are like, I'm ready to push, there's so much pressure, know that your provider might be like, let's check your cervix. Let's make sure that you're fully dilated, because there can be some complications if someone is pushing a lot actively before the cervix is fully open, fully dilated. In that, like, if you're pushing on this tissue that's still there could be more inflammation, and that can kind of hold up the baby and hold up the process. So just kind of understand, no one's trying to be mean. If they're like, please do not push, and you're like, I really want to, like, it's such a strong urge. It might just be that's what they've kind of determined to be like, let's hold off, let's wait, try to breathe through. We'll talk about breathing in labor in a little bit, and try to just breathe out that tension instead of pushing, and let your body still do the work of dilating and opening. And then the third stage is when your baby is there, until the time of the birth of the placenta. That temporary organ comes out after your baby does. That third stage is pretty incredible. That's when you meet your baby and the placenta.
Cool. So what about being induced?
Oh yeah. So that we see that in situations where if there's like any complications in pregnancy. So for example, like diabetes or high blood pressure, those might be reasons that your providers would want your baby to maybe be born before term, just to like prevent any complications, like such as preeclampsia, just not giving as many opportunities for that to develop. And then also if like, as I was saying, like nearing 42 weeks, the placenta might not be working as well. And so a lot of times providers will recommend scheduling an induction late, which we might call like a late term induction. So you're still term, but just having that kind of on the books scheduled, so that like if your body hasn't gone into labor spontaneously on its own, then you have that scheduled at the hospital, so that you kind of know you have something in place in case your body hasn't done that by then. But yeah, I would just have that conversation with your provider. They'll often bring it up, but that we commonly see that practice, just so something's there. And then that can involve different techniques and medications. And this is also relevant because even if your body starts labor on its own spontaneously, you might see these medications used just because if they're seeing like, you know what, that dilation that we're seeing, like progression, and then the contractions they spaced out, or like, we didn't see as much dilation as we were kind of expecting, I recommend using this medication. So the Foley balloon, the first one's listed here on this screen. Foley balloon is a device that mechanically can open the cervix. So I don't know if anyone has seen like Foley catheters that are used to like use I guess if you have like a catheter up inside of the bladder to like then have like after surgery or something. And if you have a C-section, you'd have one of these as well, or an epidural, which we'll discuss. But it's the same device where like it's introduced inside the cervix, and then that balloon is inflated using water usually to open up the cervix, and that can kind of cause prostaglandins to be released, and then to help kind of encourage the cervix to start dilating on its own, and sometimes contractions as well. And then misoprostol is one of the more common cervical ripening agents that is introduced in the body vaginally or orally, sometimes rectally, to like soften the cervix. Again, it's prostaglandins that it's introducing, and the thought is then to just either like that on its own might invite the uterus to start contracting, or it's used to at least soften the cervix, and then later Pitocin can be introduced to it's synthetic oxytocin. Our body is producing oxytocin to induce labor, causing our uterus to contract. It's also produced like when we're breastfeeding, it's produced in orgasm with sex, and like that's orgasms related to like contracting of the uterus, labor also contracting the uterus. So that Pitocin is a synthetic form of that natural oxytocin. And now there's like very good protocols. In the past, there was kind of some like regulations had to be instated because providers were kind of like amping up the Pitocin too high. There were complications associated with that. Everywhere I've practiced, everywhere I've seen is like really responsible about starting with like the lowest dose of Pitocin possible and moving up very carefully. Your like nurses, midwives, OB/GYNs are like very carefully monitoring that. So of course, like have that conversation with them, any questions or concerns, but I see it used very responsibly. And then you also might see those medications after delivery if there's any heavy bleeding, because again, it's going to help those are going to help the uterus contract and prevent bleeding. So hopefully you don't see them for that reason, but if you need them, they're there. Your providers will bring them.
Interesting. So now that we know all about labor, how does one stay comfortable?
Yeah. Okay. Yeah. And this is
because I think that's part of the nerves, right? That's part of the nerves.
Right. Totally. Yeah. I think like thankfully, in society, we like modern day society, we like don't have that much pain typically. And so like labor, we have air conditioning, we have like things, as an example, like, so I think it can be frightening to just anticipate this like pain that is new for most people. Not to mention if you haven't been in labor before, it's like all a new process. So including the intensity of those contractions. I think having some strategies in mind ahead of time can help. So breathing is so helpful. And that might look really different in different parts of labor. So like initially it could just be kind of like deep, slow breaths. I'm just going to do, you can do these at home. I'm just going to do them in front of these guys embarrassingly, but yeah, just like.
We'll do it with you.
Yeah, we can all do that. And not the exhale. You can just kind of focus on exhaling tension from your body. That can really help. And it also just, the inhale is just bringing in that important oxygen into the lungs. And if you can kind of keep it slow, not hyperventilating, because then you're not bringing in as much oxygen, try to keep it as slow as possible. But kind of listen to your team. If they're like at some point, sometimes with pushing, or like I was saying, like the intense urge to push and maybe it's not quite time to push, maybe more forced exhale might help as well. Just letting out that tension, okay? So different breathing strategies. Maybe just try to practice at home beforehand. Just deep breaths, and then feels like more like blowing out a candle while you're pushing. That kind of forceful can help too. Okay. And also, this isn't really like evidence-based, but there is like, or I mean, maybe it is, but like our kind of oral musculature and that of our like anus and vagina, like the pelvic muscles, are kind of related. So like as much as you can kind of have your like jaw relax, include like forehead relax too. That will kind of help your pelvis to relax. If everything's like really tight, it might it kind of indicate and be associated with like your face is tight and then your pelvis is kind of tight. So just everything as relaxed as possible. And then some strategies like having photos that like bring you like strength, maybe like people who are strong in your life or your dog or cat who you love, things that like just put you in the moment of like, this is what life is. So this is what is meaningful in my life. This is what makes me feel grounded and good and my strongest, best self. Images that you associate with those things.
It's like a focal point almost.
Yeah, totally. Just a reminder, like, okay, this is who I am, this is what I'm about, this is what I'm capable of. These are people who love me and support me, those kinds of things. Maybe like a little mantra that you tell yourself, like if even it's simple as like, I can do this. I can do this. Maybe you're saying it out loud, maybe it's in your head, or maybe you're sharing it with other people. Just like tell them, remind me, like, you can do this. You got this. You're the strongest. You're the most beautiful thing in this whole world. And then movement again, just like those are some ideas about some different things. So like I'll just be kind of embarrassed, like it's kind of hard on the screen, but like if you can kind of be hanging on to someone and like just like kind of swaying with them, that can be really nice. And they can just be like kind of supporting you and their arms around you. It's kind of a slow dancing thing. Rocking back and forth on a birth ball, maybe in a rocking chair. If that's available. And then, or just the standing up. And then, labor ball, like we talked about before. And then support people. I would say, like, I think it is important in labor to be with people who are super affirming of you, who you feel like you can be both your most vulnerable and your strongest with, because that's labor and birth. You're going to be at your most vulnerable and at your strongest. So those people who can go there with you, that's who you want with you. If they can't go there with you, you don't want them there. You don't need anyone who's going to be reminding you of drama or questions that aren't important and like not a part of this really central experience. So, whether that's your partner or not your partner, your mom or not your mom, they're your partner's mom or not their mom, or if you're going to have a doula, obviously it's 100% up to you. All of these people are 100% up to you. You get to decide who's in that room with you. But if you're searching for a doula, like I would really encourage you to meet with them ahead of time, a number of times, and just make sure like I feel really good with this person. I can literally open with this person. That's who you want there. And for cesarean section as well, it's like, birth, it's just intense, whatever form it is. And you want the people there who are going to support you. Water. So like a lot of hospitals, some do, I'm not aware of that many in New York because real estate is such a premium. They don't have like room for like big spacious tubs, but if you have like a tub available, that's nice to submerge yourself in. That can kind of help with contractions. Some people who give birth in birth centers will elect to have like a water birth. But even just like a shower can be so nice to step into that shower, especially if you can like focus the jets on where you're feeling pain. That can feel really nice. Like the shower is like a head you can remove and kind of direct it where you're feeling the intensity of the contractions. This water can be great and just like refreshing, pick up a little bit more. And then massage. So this, one of the best things I've seen work in labor to support people. Would either of you be able to, can I touch your back?
Yeah, of course.
Is that okay? Do you mind coming in front? Okay, so Sarah's being so nice. So oftentimes people are so sorry, can you come up a little bit?
A little bit?
Yeah, or a little more. Okay, is it okay if I touch you?
Oh, yeah.
Okay, so a lot of times here is where people are feeling really intense contractions, the lower back, especially in the kind of towards the beginning of labor. So just kind of some counter pressure can feel really good and rubbing, but also a hip squeeze. So like this is the best counter pressure, kind of pressing inward. So and go ahead and teach your partners, teach your support people about this. Your doula, they probably are. Hopefully your doula knows about this. And like you're kind of pressing inward. Oh, thank you. And in both like squeezing in laterally and from the back to kind of just And really as a laboring person, you just say there, like move their hand so it's in the right spot. Like you're gonna know, like that feels good or that doesn't. And then like just kind of doing that with each contraction can be really helpful. Your support, thank you so much, Sharon.
Of course.
Your support team they're gonna be really buff after this. Like they're just gonna have like biceps
put them to
of
work.
steel. Yeah, triceps and biceps of steel. So that's fine. You put them to work. You're doing all the work. So let them do that. And then music can really help too, whatever that is for you. That's gonna be different for each person. And we kind of talked about imagery, but yeah, like a picturing your baby, picturing meeting your baby. That's like can be really motivating, as you can imagine.
These are all very helpful. What about if you want to go the med route?
And then medications.
I want meds.
Right.
What are my options?
Yeah. So like narcotics, you might be offered, so they can be given through an IV that like often in a hospital setting, an IV will be placed, even if it's not immediately connected to like any kind of IV fluids or medications, but often just in case there needs to be emergency access to provide one of those things. So often like, maybe in the crook of your arm or hand, usually they try to aim for the hand just so you're not like, you can bend your arm and stuff. You might have an IV placed there. And then a narcotic can be given. It does not take the pain away. Usually it takes the edge off of the pain. And then you typically need to be staying in bed because it can make you drowsy. Sometimes like it's nice for people to have that because it can just get them through like the next hour where they can kind of like just take a break from the intensity of the pain. We don't give that medication if we anticipate that someone is really close to delivering, like less than an hour or two, because the narcotic is actually shared with your baby because it's going into your bloodstream and then it gets shared with baby. So that is something to consider. Some people are like, I don't want my baby to have any kind of narcotics, but it usually is cleared and then someone it will clear by the time. So that's why the timing is important because then it won't be, the baby won't be born with that in their system anymore if it's given at least an hour beforehand. If then you're just all of a sudden you give birth, just know that the pediatrician, the pediatrics team, child support teams, they're just going to pay extra close attention to your baby as they would anyways, but they might just be a little bit closer monitoring. And then the epidural, that also involves the administration of a narcotic with lidocaine, numbing medication, or like a relative of lidocaine in the same family. That is placed through into the back, into the spinal, it's the epidural space in the spinal column. And so that will cause usually the contraction. The goal is to obviously take away the contraction pain. It will also take away feeling in like whatever is below that level of the spine, because our nerves come from the spine, right? They radiate out from the spine. And so whatever is affected below that will also be kind of numb. So you might not have like full sensation in your legs or your bladder. So that's, I alluded to earlier that like a urinary catheter is also placed because we need to be draining the bladder since you don't have that sensation of like, oh, I need to pee, or maybe the control of your bladder anymore either. And then it can affect, you should still feel pressure though. So that can be helpful, like, so that you kind of know when your contractions are. That's helpful in pushing, because then you can kind of know like, okay, I know when to push, this pressure is more intense. And like here it says the epidural may slow labor. We typically see it can slow it on average about an hour. But like, people have, it's very, very common to have epidurals now. And it's really just that, an hour. So just know that that's a resource, and anesthesiologist would place that for you if you wanted it to. And know too that like sometimes people are like, I want an epidural right away. Sometimes they might recommend waiting till a certain dilation or a certain like stage of labor, just because they don't want to stall out labor if an epidural is placed too early, because it's more likely to stall labor if it's placed very early. So just know that that could be part of the discussion. And then also once you are like, yes, I want an epidural, I'm ready, know that like you do need to have a bunch of IV fluids placed ahead of time, because we want to prevent the blood pressure lowering too much. So we put a bunch of volume into the bloodstream so that to prevent that blood pressure from dropping, because you can imagine like the blood, like everything relaxes, like including the blood vessels. So that's kind of a way to prevent that from happening. And so sometimes patients like, where is my epidural? But it's like, we're just waiting to get these fluids in to prevent complications. Not trying to torture you. And then usually the urinary catheter is placed after the epidural is placed, so you're not feeling that, at least. Those are some of the details involved in the epidural.
All right. So what about C-sections?
And then, so you might have a C-section scheduled. Say you've had a C-section in the past and you decided with your provider that you wanted to have another C-section. Maybe your baby is breached and not able to turn that baby. We don't really see vaginal deliveries of breech presentation anymore, or that commonly. And so just with your provider, maybe you made this plan of scheduling a C-section. Or maybe you have gone into labor and a complication arises. Maybe your baby's heart rate is kind of giving some distressing signals. Like if it's going down a lot at certain intervals, then it can reflect blood flow through the placenta and reflect your baby's oxygenation status. So that's why everyone's always watching your baby's heart rate really carefully. And so like with a C-section, just know it kind of depends. Like if you already have an epidural in place, they can use the epidural for all your numbing medications. If you hadn't had an epidural and your provider was like, we need to go to the emergent or the operation room, the OR, I recommend a C-section. You might need to have general anesthesia because there isn't time to place an epidural. So you would be asleep during that, and then you would be in a recovery room and could meet your baby when you wake up. So sometimes that we do see that. And then the recovery for C-section is a little bit longer. So typically like after a vaginal delivery, if there hasn't been any complications, someone would stay like 24 hours in a hospital, mom and baby, or laboring person, birthing person and baby being monitored for those 24 hours. C-section, it can be 2 to 3 days just because there is more of the open wound and they want to be checking on that and checking for signs of bleeding and infection and anything. Some people, after an initial cesarean section, will go on to have a vaginal birth after C-section, a VBAC. And so that if someone is interested in that, I recommend having that conversation really early on in pregnancy so that you kind of know what your provider recommends and what their approach to that is. And, some people want that because they don't want to have, again, like they've had a C-section in the past and they don't want to have like the higher risk of bleeding and infection that comes with cesarean. But some providers might be a little bit wary if they didn't do it themselves and they didn't know where the incision site was placed exactly, if they don't have like an operative report. And so it's just important to have that discussion so everyone's on the same page.
All right. So to wrap it up, why don't we discuss quickly what we should talk to our birthing facility about?
Yeah, so kind of like making a plan, but when, like we discussed earlier, like when do you want me to be in touch with you? When do you want me to go to the hospital? Like what would mean, like what would be the requirements for me to like stay? Because some people have this experience of like, I'm in labor and then they go to the hospital and it's like, well, not quite, maybe you're having contractions, but your cervix hasn't changed. Please go home. So just maybe have that conversation so you kind of know what to expect. We kind of went over some of the requirements of like probably like maybe they want to see that your cervix is somewhat dilated and make sure your baby's doing okay. So yeah, fetal monitoring. More and more hospitals are kind of moving towards consistent or what they call continuous fetal monitoring. So there's 2 monitors that go on the maternal abdomen. One to monitor baby's heart rate, and then another like often at the top of the uterus, top of the abdomen to monitor contractions. And then that's where they're looking for like changes in baby's heart rate to know, are there any potentials for complications? Like, is baby's circulation okay? Is baby's oxygenation okay? Sometimes in early labor or certainly like birth center facilities that they might use intermittent monitoring where they're not constantly listening, but they are going to like use a Doppler to listen to your baby's heart rate, like every 30 minutes to an hour, depending on the stage of labor. We kind of talk about IV fluids, definitely with an epidural or like Pitocin in place. And also with fetal monitoring, if any medication is being used, certainly continuous fetal monitoring is going to be in place, or an epidural. And then, yeah, just hydration. If it's kind of seen like, this person isn't really like able to get the nutrition and hydration they need orally, we need to provide that with IV fluids. And then, yeah, maybe just talking to them about like, do you place an IV right away? Do you wait till a certain moment in labor? And then like, do you allow for walking and moving? Often if there is continuous fetal monitoring, it's a little bit harder, but it can be possible, especially if the hospital has like the wireless monitors. Sometimes the signal can be hard. Just know your nursing team, provider team is going to be chasing around your baby's contractions on your belly pretty constantly if there's any interruption in the signal. And then, yeah, see if they have tubs. That's cool. See if they have showers you can use. If you can listen to music, who they invite in, that changed with COVID. So some hospitals right now, it's just one support person, some just two. It used to be like, anyone can come, and then, yeah, ask them like, okay, what happens when the baby's born? Can my baby be placed on my chest? That can be really helpful for baby's transition into life. If there's a complication though, they might recommend like, let's bring baby over to this warmer. Maybe we need to help your baby breathe. Maybe in emergency setting, they're going to be a bunch of people that, not expecting this, but worst case scenario, like maybe baby needs support, and people are going to be rushing around your baby and moving your baby to like a little warming table near your bed. And then again, like, yeah, how long might I have to stay in the hospital or birthing facility after birth? And then does the hospital or birthing facility have lactation counselors, lactation support staff? Because that can be really important if someone wants to breastfeed, to kind of get that support early on within like the first hour of birth, ideally, if not soon thereafter. And if you decide that you want to feed your baby with formula, they have formula, like they will have formula on site, and just kind of communicate with how your baby's needs can get met.
Awesome.
Yeah.
All right, well, I guess we'll now open it up to the group. If you all would like to send questions into the chat, now is your opportunity to do so. I know today's conversation was super thorough and educational about all things labor and giving birth. I learned a lot.
Oh, good.
No, so much.
Okay.
So yeah, now's your time to ask your direct questions. We'll give you guys a couple of seconds.
If you still want to share your feelings, how you feel, that's fine too.
Hopefully you're feeling a little better.
Yeah, right.
A little less nervous. I will kick it off with I have a question. So when is the best time to start creating your birth plan? Because obviously there's a lot that goes into like figuring out how long you want to try to labor at home before going to the hospital, or like knowing that once you get to wherever you're giving birth, if you're getting IV fluids, your ability to move around is a little more difficult. So it's like, what's the right time to start visualizing what you want your like ideal scenario to be?
Yeah, that's a great question. I think right now, like anytime. I think like if you're learning about labor and delivery and pregnancy and you're like, that sounds appealing, I learned about this is important to me, write it down, and if nothing else, even if like you never share this piece of paper with your birth team, like at least you can be visualizing like, this is the experience I want, and identifying this is really important to me. Maybe some other things like I feel like you give or take whatever, but like certain things, this is super important. I think identifying those is great. Wonderful. And it's hard, like I guess anyone who attends births, like I think if in training, say like we're going to be trained to identify patterns, right, and deviations from those patterns, but we also know we can't exactly predict everything. So like a birth plan is super important and useful, I think, to visualize and kind of familiarize ourselves with the birthing process, but like also just knowing that like no one can 100% plan everything. So I just don't want to set people up for like disappointment if we have like a very concrete picture of how things might go. You know?
Right. You have to be prepared to deviate from the plan.
Yeah, yeah. And just kind of just like have a few things that are super important and meaningful to you.
Okay.
Yeah.
We have a question from the chat. The question is, how long does it take to deliver the placenta after birth?
Oh, great question. That it can vary a little bit. Often, like, so the contractions of the uterus are also going to help, like they help birth your baby, and they'll also help birth your placenta. So you might be like, I thought this was done. I just birthed my baby. I'm having
when did
another
it stop?
contraction. I know. So they like they go on for a little bit, because then the contractions help birth the placenta, and then it helps the uterus contract to really like close off those blood vessels. So kind of like, you know, we get a cut on our arm, we put pressure, right, to stop the bleeding. The uterus is trying to do that on itself to like close that wound. It's like where the placenta was attached to the uterine wall, there's a big wound there. So it's trying to like clamp down on that area so that there's not as much bleeding. So to answer your question though, the placenta could like be born immediately after the baby. If we see like it's taking a while, like providers might be like, okay, 15 minutes have passed, let's do something to kind of help this out. Maybe they would increase like give a little bit more Pitocin after birth to help like the uterus to contract and help birth the placenta. They might even like use what we call gentle cord traction on the cord. So like guarding your uterus from the outside so it doesn't like come, if it's still attached, it wouldn't like bring out the uterus. And then just kind of gently pulling to kind of guide the placenta as long as it's already detached through the vaginal canal so it can come out. Interesting. Yeah. So usually like usually by 15 minutes it would be birthed.
Oh, she said, thank you.
Oh, you're welcome.
Do we have any other questions? We are right at 7 o'clock.
All right.
So I think if we don't have any other questions, we will wrap it up for today's session.
Okay, cool. Thanks you all. I hope that you all have wonderful experiences, and let us know how we can support you. Let your provider team know how they can support you, and just wishing you and your families all the best. You'll be great.
Amazing. Thank you.
Thanks, Sarah.